My name is Sarah Ju, and I am one of Stanford's anesthesia residents. I am also a part of Stanford's Global Anesthesia Residency Pathway. This lecture will discuss the supraclavicular nerve block. The learning objectives for this lecture include indications, brachial plexus and ultrasound anatomy, side effects and complications, the steps to perform a supraclavicular nerve block, and tips for placement. The supraclavicular nerve block is a regional anesthetic technique used as an alternative to general anesthesia or used for post-operative pain control for upper extremity surgeries from the mid-humerus through the hand. This would include surgeries for the arm, elbow, forearm, and hand. It is commonly known as the spinal of the arm. Historically, the associated risk of pneumothorax was likely responsible for its decrease in popularity. The emergence of the ultrasound created renewed interest in the block, as well as other upper extremity blocks, with the identification of the brachial plexus, lungs, vasculature, and other anatomy. Of note, sparing of the distal branches, especially the ulnar nerve, can occur. General contraindications to peripheral nerve blocks also apply to the supraclavicular block, including patient refusal, allergy to local anesthetics, infection or malignancy at the injection site, existence of pre-existing neural deficits in the distribution of the block, and coagulopathy. Of note, the supraclavicular block is known as a deep block site that is considered non-compressible, so coagulation guidelines should be followed accordingly. A more superficial block should be considered for patients on anticoagulation therapy. In particular, for this block, additional caution is advised in patients with severe pulmonary disease. The risk of phrenic nerve palsy is lower than with interscalene block, but cannot be reliably avoided. Thus, in patients who cannot tolerate a 30% decrease in respiratory function with phrenic blockade, an axillary or infraclavicular block may be a better choice. The anterior rami of C5 to T1 form the brachial plexus, which roots exit the cervical spine to form the superior, middle, and inferior trunks that travel between the anterior and middle scalene muscles. Each trunk divides into an anterior and posterior branch, which rejoins to form the lateral, posterior, and medial cords as they travel distally to the clavicle. The supraclavicular approach blocks the brachial plexus from the distal trunks to the proximal cords. The approach is usually targeted at the divisions level. The distribution of the supraclavicular nerve block includes the axillary, radial, ulnar, median, musculocutaneous, and the medial cutaneous nerves. It does not include the intercostobrachial nerve. If the patient may have a tourniquet or medial arm surgery or posterior arm surgery, an additional intercostobrachial nerve block may be appropriate. The intercostobrachial nerve is not part of the brachial plexus, as it usually comes from T2 and occasionally T1. In addition, as opposed to the name of the block, the distribution of the supraclavicular block would not include the supraclavicular nerve that supplies the skin over the clavicle and acromion. It also does not block the suprascapular nerves. These two nerves would be covered by the interscalene nerve block. At the supraclavicular fossa, the brachial plexus and subclavian artery lie above the first rib and pleura. The subclavian artery could be seen as a round, dark, or anechoic structure, and the parietal pleura and first rib can be seen as a white or hyperechoic structure deep and lateral to the subclavian artery. The brachial plexus is located lateral and posterior to the subclavian artery as hypoechoic round nodules. The subclavian vein and anterior scalene muscle are medial to the subclavian artery. The dorsal scapular artery commonly passes through or within the area of the brachial plexus. Adjusting the transducer The upper, middle, and lower trunks of the brachial plexus can be individually identified as they join together at the costoclavicular space. Of note, the ulnar nerve can be spared as the lower trunk is located medially, and medially is close to the rib and pleura. The necessary equipment for the nerve block should include the following: a disinfectant and antiseptic such as chlorhexidine gluconate or povidone iodine, a high-frequency ultrasound probe with a sterile probe cover and gel, local anesthetic for the superficial layer, which is typically 1% lidocaine, and also regional block local anesthetic, which could include bupivacaine, ropivacaine, lidocaine, or mepivacaine, 20 to 30 ml or cc syringe with extension tubing, a short bevel block needle, either a 10 centimeter 18 gauge for a continuous catheter or a 22 gauge for a single injection, and optionally a nerve stimulator. For any block, there must be informed consent. There should also be a pre-procedure pause and timeout to identify the correct patient, surgery, site of surgery, and other factors. This block can be performed in the supine, semi-sitting, or slight lateral position with the head turned away from the side to be blocked. Most common, though, is the supine position with the ipsilateral arm by the side. Scanning is started just above the clavicle around its midpoint. A towel could be rolled underneath the ipsilateral shoulder for positioning. Mild sedation may also be provided, though some patients may not require any sedation. To start the block, the skin should be disinfected. The ultrasound probe can be placed in the supraclavicular fossa perpendicular to the clavicle with an ultrasound probe cover. For the best view, the transducer is tilted caudally or away from the head. A view of the subclavian artery should be obtained, with the brachial plexus seen as a collection of hypoechoic round structures, posterior and lateral to the artery. Color Doppler should be considered before a needle insertion to rule out the passage of large vessels that include the dorsal scapular artery, transverse cervical artery, suprascapular artery, in addition to the subclavian artery. Then, consider inserting local anesthetic into the superficial skin before needle insertion. After needle insertion, from lateral to medial, advance the needle through tissue layers towards the brachial plexus, considering the hydrodissection of tissue layers. This means you can inject small volumes of saline or local anesthetics to guide the trajectory of the needle path. After negative aspiration, inject local anesthetic. When the injection displaces the brachial plexus away from the needle can be advanced closer to the plexus. If there is no spread around the brachial plexus, the needle may need to be repositioned. Typically, 20 to 25 milliliters in total is required for adequate blockade. Lower volumes could be considered for older patients. The supraclavicular block can have one single injection that you can see in the bottom image with a blue color as anesthetic spread, or two separate locations of injection that you can see in the top image. Here are some tips. A nerve stimulator can be used, but is not necessary if structures are well visualized with the ultrasound. When you're doing the block, you should stop advancing your needle if the patient has symptoms of paresthesia. In addition, the needle tip should be visualized at all times to prevent pneumothorax and avoid vasculature. A color Doppler is also recommended before needle placement. Multiple injections may increase speed of onset and success rate, but may carry a higher risk of nerve injury. Similar to other peripheral nerve blocks, this nerve block also has risks for infection, bleeding, neuropathy, and rarely nerve damage. In addition, the supraclavicular nerve block has a risk of pneumothorax, which has been decreased with the use of ultrasound. Side effects include transient hoarseness from ipsilateral laryngeal nerve block, Horner syndrome from stellate ganglion blockade, and hemidiaphragmatic paresis from a phrenic nerve blockade. Local anesthetic toxicity from intravascular injection and vascular puncture are also possible. In summary, the supraclavicular nerve block is an effective block of the brachial plexus for arm, forearm, and hand surgery. Side effects or complications include Horner syndrome, phrenic nerve palsy, ipsilateral laryngeal nerve block, and pneumothorax. The ulnar nerve may also be spared as the inferior trunk of the brachial plexus lies medially. Ultrasound is recommended to prevent pneumothorax and other complications. Finally, caution should be taken in patients with severe respiratory disease, as this nerve block could cause a phrenic nerve block. Now here's a board exam question. A 40-year-old man who is scheduled to undergo repair of a tendon laceration of the left hand has complete anesthesia in the median, radial, and ulnar nerve distributions after supraclavicular block. 2 hours of tourniquet inflation are required for completion of the procedure. The most appropriate next step is an additional block of which of the following? A. Axillary nerve, B. Intercostobrachial nerve, C. Lateral antebrachial cutaneous nerve, D. Musculocutaneous nerve, or E. Stellate ganglion. The answer is B. The intercostobrachial nerve. I just wanted to briefly go over the intercostobrachial nerve block as it is used as a supplement with supraclavicular nerve blocks. This nerve block is for surgery involving the medial or posterior upper arm, or when a tourniquet might be used. The nerve arises from T2 and occasionally T1, and the approach is done along the axillary crease. You inject 3 to 5 milliliters of local anesthesia subcutaneously, superiorly, and inferiorly along this crease with a 1.5-inch 25-gauge needle. You are able to use ultrasound in order to visualize the nerve better, and this nerve block is great because there are rarely any complications. Here are the references I used to make these slides. This concludes our lecture, and I hope you learned a lot.